Good afternoon, everybody. We'll try to get started. I know we've shifted here. We're going to probably have to truncate this session a little bit, which is a little disappointing because there's some incredible topics here. If we have time at the end, we're going to have some panel discussion, but we're going to let each of our speakers walk through consecutively. We'll ask you to hold questions, and then again, if we have time at the end, we'll do that. I'm Jim Fortenberry. I'm a pediatric intensivist, and I'm Chief Medical Officer at Children's Healthcare of Atlanta and Emory in Atlanta, Georgia, and it's an honor to be here. So many programs and presentations are around topics that maybe the people in the audience haven't experienced or don't have, haven't had the insight on a particular situation. I think this is one that we can all agree everyone in this room has probably been impacted in some way. As we talk about the impacts of maintaining a high-functioning ICU during and past the pandemic. I'm going to introduce our speakers and then have them just come up one by one. Our first speaker is going to be Dr. Sri Deshpande, who is Medical Director for Heart Transplant and Advanced Cardiac Transplant Therapies Program. He's Associate Professor at Children's National Medical Center. He's going to be speaking about PTSD and moral injury in critical care following the pandemic. Secondly, pandemic challenges and solutions in ECMO nursing. Bernadette Elliott, who has previously been at Brooke Army Medical Center, an adult ECMO transport manager there. She's actually currently pursuing her nurse practitioner degree in psychiatry, which is wonderful. Thirdly, creating a culture of resilience in your ECMO team. We have the privilege of having Dr. Kate Porterfield, who runs the program at Bellevue Hospital in Survivors of Torture, a fascinating topic, and I guess for many of us that makes sense to feel this connection. And then finally, Heidi Dalton, who is a legend in ECMO. She is Medical Director of Adult and Pediatric ECMO with ANOVA and is engaged in a huge variety of research and industry work in the field. So with that, we'll start off with Sri to step up.
Awesome. Thank you, Dr. Fortenberry. Thank you to the program chairs and organizing committee. We feel the energy. This also has been incredible. So even though the topic is a little bit dark and gray, I've intentionally chosen the backgrounds and the themes to reflect the energy that we really are feeling at this also. So I have no disclosures, but the disclosure that obviously I'm not an expert in psychiatry or psychology, like some of our speakers are, but I am a cardiac intensivist, and like many of you, went through self-isolation for the first 9 months of the pandemic, where I lived out of my basement. And so we have been there. We've been at the forefront of the cardiac ICU, so some of the thoughts are mine, but really my job is to introduce the topic so that we can get started, and then the three incredible speakers that follow will get into a little bit more detail in each of these topics. So with that, the title itself, PTSD and moral injury in critical care, I have a little bit of an issue with it, so I'm going to strike out the moral part. Morality to me is a little bit more personal. Rather than that, I would use the word psychological or mental injury in critical care because that's a little bit more objective. I can handle that as a cardiac intensivist. Getting to the morality of it is a little bit too heavy for me. It's also a little bit more objective, and it's also where the data is coming from, right? That's where the measured data and all of the information that gives us where we are and where we should be, all of the interventions are easier to do when we acknowledge and talk about the psychological injury part of it. So that may be controversial, but that's my position, like I said. So this was a huge human experience. This is way beyond a healthcare crisis. Nobody should call it that because this was way beyond that. This was way beyond a pandemic because this affected every single aspect of life, as we know. So this really was an experience for the humanity. But when we do boil it down from science standpoint, obviously it's a really important topic. And so I went on to PubMed and did a Google and a PubMed search on just PTSD and COVID. And within the last 20 months, there are about 1,600 publications on PubMed on just PTSD and COVID. So thankfully, a lot of smart people are looking into it and trying to help us understand what's going on here. But when we talk about healthcare workers and ICU people and get their impressions, this is the word cloud we generate, right? It is beyond PTSD, it's beyond moral injury, mental injury. It is the whole spectrum of human experience that is now narrowed and funneled through this COVID lens. And suddenly all of these fears and anxiety issues and distress issues are at the forefront of our discussion. So again, at least we are talking about it, both at the personal level, but more importantly, at the system level for all of us. So this is a direct quote from one of the papers, and it summarizes everything that I wanted to say. So I'm going to put it up right at the front, which is that, obviously, this is a stressful work-related environment, which is the ICU in COVID times. And it is specifically stressful because we are involved in management of critical medical situations, caring for severely traumatized people, frequently witnessing death and trauma, operating in crowded settings, and interrupted circadian rhythms. So these are all very basic scientific things that we're going through and experiencing them, and that is leading us to experience the stress and the trauma that we are then measuring, talking about, assessing. So just quickly to go through in a couple of slides, the cardiac ICU ECMO team part of it, but even the ICU team in general, had a couple unique stresses and a couple unique vulnerabilities. We were suddenly asked to perform new roles. What were these new roles? We were doorkeepers. We were the people that were required to tell the families that you cannot come in and spend time with your loved ones, even though they are on ECMO, even though they are on ventilators because they're under isolation. So we have a doorkeeper responsibility now. Oftentimes, we were the only connections between the families sitting in the waiting room or outside the hospital through iPads and the patient. And that's a new role for us. We turned then into family counselors. Every nurse, every respiratory therapist, and every physician that was at the front line also had to be family counselors. And more importantly, we also became victims now. That's a new role for us. And this was physical violence against providers. Lots of places and lots of healthcare workers experience that firsthand, which is being victims of actual physical violence from patients and family members. That was just upset. Brand new role for us. We also were called heroes, right? Lay media and families also put us up on pedestals and gave us the title of being heroes. But as we all know, with great power comes great responsibility, right? It's given to Spider-Man, but we know it's an older quote than that. What was this new responsibility? Well, the new responsibility was functioning in this environment. And that added a new level of stress. If we realized that we were not up to it or we were not performing at the superhero level, then we had a guilt associated with it. We were blaming ourselves. Or we were going over and above our weight to punch where we should be punching. So we were ignoring self-health, self-care, and outperforming our own level of performance, and then stressing ourselves out, self-exhaustion. So there was a paradox of coexistence. Positive and negative emotions very commonly coexisted within these healthcare providers, specifically ICU teams, at a very high level. And so what happens with this when this coexistence occurs is dependent on that individual and the individual coping capacities, and the result is what manifests as either a positive outcome or a negative outcome, and in a lot of people, that was a negative outcome. 3 really important statistics. 20 to 53% of healthcare workers experience psychological stress, depression, or stress-related disorder that met DCM criteria for PTSD. 9% had suicidal ideation, and this includes lots of different countries, lots of different setups for healthcare. And 58% physicians experience burnout. Right? There were some very specific factors that were identified that were risk factors for all of these bad things from happening. Isolation, we were working in an isolated environment. Social support, once you start isolating yourself, protecting your families, your friends are now locked at home, your social support went away. Level of experience became a huge deal. Physicians with 3 to 5 years of experience were at highest likelihood of a physician burnout experience. This was completely new to them. They were questioning themselves, did I get into the right field? Female gender was consistently identifying as a risk factor, and being COVID positive as a COVID experience, if you had that, that reflected into your well-being. So we know that in the last 2 minutes or less, external factors were also playing a big role. Ventilators were scarce, and now you're making the decision who would qualify for a ventilator, who would qualify for an ECMO, and how many days on ECMO we should keep a person because the next person needs that machine. Scarce resource. Set up infrastructure. Children's hospitals were taking care of adult patients. Again, a stress added. And visibility of leadership was a huge role. Were the leaders present, rolled up their sleeves, and a part of the team? Or were the leaders giving orders from somewhere else, and you were feeling like your voice was not being heard? Added a huge lot of stress to that. Lastly, silver lining, but we'll get into a lot more detail, hopefully, with the next talks. It taught us newly about how to prepare ourselves. Are we going to train the next generation of the ICU teams better to take care of themselves and the patients better? Are we going to adapt and grow? There's something called post-traumatic growth that is now being researched. Throughput and sharing. For the first time, vaccines and technology came out faster than it has ever before. How are we going to leverage some of these initiatives to better prepare us for the next one that's coming for sure? And sharing, Heidi might talk about it, was at a completely new level. Knowledge, best practices, experiences. So there were some positive things to take away from it. But to summarize the theme, humanitarian crisis of COVID has experienced our limitations as caregivers and our vulnerability. Third of the physician workforce in ICUs is experiencing stress disorder already. We understand the external and internal factors related to it a little bit better. And what we really need is a massive effort at addressing this as a community. On that note, I want to thank the opportunity to bring up this topic and share my thoughts. Thank you all.
Thank you. I'm Bernadette Elliott, and I have no disclosures. I do have to say that this is not like an official record from the program at Brooke Army Medical Center or the Department of Defense, but only the recollections of me during this time that we're discussing. The anticipation for us was great because geographically Texas happens to be located in the middle of the United States, and as we watched the waves come in from the East Coast here over, a lot of us were hearing how bad it was from colleagues and friends and family that were geographically located in other places. And watching the reported data, I think every one of us was probably looking at this map multiple times a day before we went to bed and as soon as we woke up. Our program, personally, we had our active duty were deployed forward to the areas that were hit harder, and so that right away depleted our staffing matrix by 50%. We do have a core group of civilians that are supposed to be able to man and maintain operations during this, and so we were able to keep the doors open, but it definitely did decrease our capacity for both ECMO and transport ECMO, as well as just critical care. We had a loss of active duty physicians, nurses, respiratory therapists, and medics that are all a very active part of our program. While we were limited on our beds, we did try to maximize the capability of the city by loaning equipment for beds that we didn't have to outlying, centers that were in our area, as well as disposables. And I know that ELSO maintained a really good equipment and disposable tracking on their webpage, which I think was an invaluable thing for us to have developed in this time as well. When it finally arrived, we also suffered the isolation not only of our patients and the PPE and the waxing and waning of supplies that everybody suffered initially, but our self-isolation and isolation from just gathering together as a team outside of work. We definitely tried to expand our capacity, as many places did, and that was by pairing and expanding our patient-to-nurse ratio and putting patients where we normally did not have them. As we started to see the staff casualties, I recall, the terror as we would get calls from cities around us, please, please, please take this patient. We didn't have beds. Physicians were literally running a list of referrals that hopefully we would get a bed for, but every single day that list just got longer and longer. Our response, initially, we were also manned with doing a big testing site for our city, and so I think everybody's, city had some sort of tent city built up there, but our military that was remaining was a big part of that. And so then we really started to feel the shortages, not only of equipment, but of our staffing, and we started doing team assignments. Luckily, I had a fabulous medical director that for our ECMO program decided to look at our documentation and decide what was really absolutely essential. And we pared that down significantly. We started doing some cannula modification. They actually started doing some right pulmonary artery cannulas for these patients as we started to see them not progressing off of pump as quickly as we wanted to, and their pulmonary hypertension was just getting to be a huge factor as the fibrotic stage of COVID set in for them. And we started adjusting our ECMO referral criteria. Our age cap started getting lower. Our comorbidities, we weren't tolerating as many. And we did have some sentinel events. One sentinel event that I recall distinctly because of the isolation practices, and we were trying to keep our nurses out of the rooms, and we did have an accidental decannulation. So in our refinement of this, we did relocate to a pre-op and PACU. I remember when I would come in, we had a COVID unit, and then we had COVID unit expansion to a second unit, and then we had COVID everywhere. And then we started going to the PACU, which was an open bay, and that allowed us to pair primary nurses as well as our specialists, and then it was just like one big team. What we found with that is that it wasn't great for our patients because we were still trying to wake them up, and we did not have any sort of diversional stuff for them in there. We didn't have great Wi-Fi because they don't usually need that in the PACU. And these patients are awake next to somebody that's doing horrifically bad, and they have a curtain between them. We started preparing because the numbers still kept coming upon us, and so now we're talking about ventilator pairing and paring down our documentation even more, which included the CRRT and ECMO flow sheets because, that's so labor intensive, and now we're down to bare bones staff. Again, we cut our ECMO referral criteria even lower, less comorbidities accepted, and lower ages. Our RCMA implementations from our accidental decannulation, we're starting to tax a little bit more. And now we're staffing testing and vaccination sites also with our hospital staff. As the testing criteria and isolation, we all suffered the different phases of that. So what did we learn from that? I feel like we learned how important closure is, not only with our patients, but their family members as well, as we were often the only link between them. A lot of us found faith or felt isolated from it as we were limited in where we could go. We learned the importance of family and having them available as a support person to our patients and to our staff. We learned how important rest was because we weren't getting any. Self-care, very similar. We were very minimal at that point, and our support systems were starting to dwindle because we were really just trying to keep ourselves together to go back the next day. A lot of us fell out from burnout, and a lot of us left those jobs for travel jobs in nursing, locums for physicians, because the money was just a little bit more attractive than where we were at that time. And lasting, thank goodness, in my program, we did not go back to long documentation at the end, but we realized that we didn't really need all of those numbers that we had been gathering for a long time. So with gratitude, I would like to thank you for your time. I would love to hear about your all's experiences as you all, mitigated these challenges as well. And in the last 15 seconds, I would just like to tell you all thank you.
Hi, everybody. My name is Kate Porterfield, and as Dr. Fortenberry said, I'm a clinical psychologist. I'm not a medical practitioner, and I had the really amazing experience during 2020 and 2021, and a little bit of this year, to work with the MICU at New York Presbyterian. And I want to tell you a little bit about it, and the way I'm going to do that is share with you how I framed the work with those teams around well-being, stress, and resilience. And some of the things I might share with you, you can actually reflect on yourself, because raise your hand if you had some stress during COVID. Yeah, that's what I thought, right? So I'm going to share with you a little bit of how I worked with the team, hoping it might feel applicable to what you've all been through. So let me begin by sharing with you. So I am a trauma specialist, actually, as Dr. Fortenberry said. My area of expertise is working with survivors of torture, war trauma, and severe abuse. So you might think, well, how did you come in contact with the MICU? And it was actually kind of funny, because I will tell you that it happened through a lawyer who I was working with on a case involving torture, who said, my wife is attending at the MICU at New York Presbyterian, and she and her team are amazing, but they are really, really carrying a lot. Would you ever talk to them? So I put together a program of webinars that looked something like this. I did 5 webinars with the attendings through the summer of 2020, and then checked back in with them again in 2021, and once the beginning of this year. I also did a series of webinars with nurse practitioners and a few with some fellows. So it's interesting in terms of what Dr. Deshpande said. This is a quote about the moral injury component of what you all dealt with during the COVID crisis. And what I just want to point out is it talks about sort of how the fight against coronavirus met the criteria for moral injury. And the thing I want to just point out is that it's not just the exposure, right, to ill patients and death. It's the personal risk that you all were absorbing to feel yourself, the fear, and Ms. Elliott used the word terrifying, right, as you saw those numbers and knowing that you yourselves and your loved ones were at risk. That's a particular vulnerability that I saw in the folks that I was talking to, but also the inadequate resources coming along with the high rate of death. That many of the physicians and nurse practitioners talked about that lack of resources made decision-making absolutely excruciating. And that sort of fell a little more into what we think of as moral injury. So let me talk a little bit about what I did. First of all, I started my work with the teams on Zoom, and I said, I'm going to teach you all something that I've learned with survivors of all kinds of trauma, which is that a frame really helps after you've had something uncontrollable, terrifying, and painful happen to you. And so when you think about that frame, we start to think about, okay, naming that it happened, right? This happened to me. Recognizing, wait, this has had an effect on me. I'm gonna actually pay attention for a minute to how this has affected me. To recognize that, wait, there's some things that have helped me during this, right? And then to go towards really that post-traumatic growth concept that actually maybe there's ways I have grown or changed from this that are even positive. And by the way, this is not to say you are only putting a rose-colored glasses approach to the experience, the terrible tragedy of working in a global pandemic as you all did. But what it's saying is you spend some time, if you can, as a team, thinking about, well, how did this affect us, and how did we change and grow? That there's a positive component that you can spend some time thinking about doesn't mean it's everything. So the other frame that I found that the doctors and nurse practitioners really liked was this idea that I use again with all my patients who've survived other kinds of traumas, which is the biopsychosocial frame. And what that means is really teaching someone that as a human organism, as a mammal, we have these different dimensions to how we function, right? And the first is that we are first and foremost, as you all know very well, a body. And our body is wired for survival. But that same wiring that helps us survive can also leave an imprint, which is why so many medical practitioners were saying, I can't sleep. I get off a shift and I'm lying awake thinking about everything I saw and everything that happened. And so that survival wiring, that nervous system activation, is actually leaving then an imprint on our healthcare workers as they process after shifts how traumatic it was. We talked about how we are also, as being humans, meaning makers. And so it's not just that you come off a shift and you're dealing with that arousal, it's that you're also telling yourself a story about how you did, how your team did, what happened with those patients. And that meaning making for a lot of medical practitioners after COVID started to get a little negative, right? People started to say, what are we doing? We don't know if we're doing enough. How could this be the way this is happening? And so meaning making was something we shined a bit of a light on during our webinars together. We would talk about what it meant to the team to have done this work. The third component we talked about was just the social self that we are as humans too, which is we need each other and we are wired for attachment, and trauma interrupts and isolates that attachment. So what I was trying to teach my wonderful medical providers was you all need to start paying attention to your bio, your psycho, and your social dimensions. Where is the stress of this work landing for you? Are you having trouble sleeping? Are you feeling irritable and isolated? Are you telling yourself negative, self-attacking things? So we would talk about that, but I do want to share with you, if any of you are thinking about doing these kinds of programs, that the doctors and the nurse practitioners, they liked if I would first teach a little bit or share a frame, and then we talk about it. There was no way I was going to open that Zoom call up and just say, how are you guys doing in the middle of May 2020, right? Because I think I would have gotten a lot of blank stares. And they would say to me, yeah, teach us more of these frames. We like these. And then they would react to them. So the other thing that everybody asked for were tools, and I'm not going to have time to give you all the tools now, but the folks, you all are doers, you like to fix things, you want to make things better. So I would use a different tool each week and then try to reflect on it with the folks on the call. By the way, these meetings were totally voluntary. They were drop-in. People could come as they wanted. So the first tool that we had was, I'm not a staff at Columbia, but Columbia and New York Presbyterian had a great biopsychosocial program set up called COPE Columbia, and this is some information about it. It was some group meetings, some online material, and some trainings and webinars. But the first tool I taught folks was in the bio zone, and I said, you need to notice what your body's telling you, notice if you're not sleeping well, notice if you're getting fatigued, and you need to introduce some kind of mitigation to that. And then we would share examples. So some folks talked about exercise, some folks talked about pleasure. They needed to go do something pleasurable after a shift to try to detox a little bit. I taught one construct that we really used a lot, which is something we use in anxiety disorder treatment, and it's called the window of tolerance. I don't know if you all know this, but the window of tolerance is a really nice construct, and I'll be quick, my time's going to run out, but that has to do with how are you doing with the stress that's coming at you from your environment. And the basic idea is this. In the green zone is where you're kind of able to tolerate what's coming at you. You all have enormously strong, large green zones because of the work you do. You know how to cope, you know how to handle stress, you can handle a changing environment. That's the nature of being excellent medical practitioners. However, what's also true is that sometimes our body pushes us into more of what we call the red zone, which is you're getting more irritable, you're moving towards that hyper-aroused nervous system response, maybe your heart's racing a little, your breathing's changing, you might have some physical pain even. And one of the things that medical professionals don't like to do is to say, yikes, I'm in this zone, I should step away. You all often charge through and finish your work, and I understand it, but one of the things we talked about was what would it mean to actually notice when you're in the red zone and step away for a few minutes or do something to try to deactivate. The gray zone is just the opposite. It's that hypoarousal coming on you from your nervous system, maybe feeling fatigued, spacey, negative. And again, what if when it came upon you, you actually had a chance to take a break, step aside, do something for yourself to re-energize? We talked about different strategies for that. The folks in the webinars liked this construct, and I just want to invite you to think about it a little yourself. I always say if you're in the red zone, don't send that angry email. And if you're in the gray zone, it might be good time for a 20-minute nap. Just a couple more things. In the psychological toolkit, we talked a lot about meaning making. And I would each webinar have some kind of reflective question. And this is just one example that we did a lot, which was we would sit together and I would say, okay, everybody name, not out loud, you just reflect on this. Think of something you're feeling negative about the work. Not in your personal life, about the work. So right now, let's do a quick example. Everybody think about something at work that's stressing you out or making you feel bad, okay? Everybody got it? And now we would do a little reflection on what part of this problem can I control? So right now, I'm going to be thinking about that. What can you be doing about this thing? And then, of course, the kicker. Think about 2020. What part of this very painful thing that I'm working in, fighting in, doing a heck of a good job in, do I actually not have control over? And that led to really powerful conversations with our team about resources, the illness, global situations of inequity that were happening around the illness, politics entering into the mix of what people were doing in the face of COVID, and all of those sort of lack of control issues, they became things that we talked about, okay, that is when a shrink says to you, that becomes a time for having to tolerate really difficult feelings. Because this part, and I'm going to wrap up, is the easy stuff. This is where I can do something. This is the painful part. And I will say that our doctors really were just beautiful, as were our nurse practitioners, about talking about this and bringing it out to each other and supporting each other. So I'll just end by saying that I did do a bit of social work with them too. Remember, we had biopsychosocial tools, and our social tools sometimes were reflections on what if we thought of our whole team as a person, one person? What would you sort of think of that person's stress is right now, and what would you wish for them? What do you wish you could do for them? So we did this exercise as kind of a building of empathy for ourselves as a team, and then we shared it. And again, it was a beautiful conversation. I mean, these teams really were hungry to talk, but they did need the prompts. They needed something to reflect. So with that, I know I'm out of time. But I just want to say that I did come back to the team in 2022, and I'm going to leave by asking you all this too. When you think about yourself as a professional, think about your knowledge, your skills, and your ability to handle stress, actually, as a healthcare professional. Think about it at you in 2019. Think about yourself then in 2020. Think about yourself in 2021. And if we had a lot of time to do a giant group processing right now, I would hope a lot of you would be able to talk about realizing how much you had achieved and gained and learned and done together during this extraordinarily difficult and painful time. So I want to end with that, and thank you so much for having me.
Well, thanks very much for inviting me to talk, and I got to go to the baseball game the other night, which was really fun as well. Here are my disclosures. So this article came out a little while ago, and I think actually says everything that you need to hear right here, so we could put ourselves back on time and I could just sit down. But since you're paying to make me speak, I'm going to do it anyway. So this article, I think, was pretty interesting. And if you think about COVID, one of the things that the COVID pandemic did was highlight a lot of things that actually were already there. But certainly, if we go through this cute little slide here, I think it did make us recognize that we need a better systems approach when these things occur, because we really weren't very well prepared. It also gave us the opportunity to develop registries, and I'll talk about that in a minute, which I think are going to have benefit for us in the future. It also allowed us to have effective ICU triage. A lot of this was the most painful part, for me at least, of the whole COVID thing, but certainly I think we did learn a lot from that. We learned how to expand ICU capacities, into parking garages and things like that we'd never thought about before. The supply chain issue is still out there, but I think COVID really highlighted that for us, not only in the United States, but internationally. I mean, how can we learn that you can't get oxygen in India from one place to another just because you can't drive fast enough on the highway and they make it all for industry and not for people? We also know about the expandable ICU staffing pool. Now, truthfully, I'm not so sure I was a fan of this. I really don't want to be cared for by my friendly radiologist, to be honest, but they did pitch in and help. And as part of that, we all learned how to do more multidisciplinary rounding. There is this whole idea now, everybody does Zoom, Teams, all those things, and we learned that you can use remote monitoring and remote care to help out as well. The things that were not so great were this whole idea of better end-of-life care, very difficult when you can't have families in there to say goodbye to their loved ones, and that's dumped on the teams. And certainly this whole issue of ICU well-being is something that I think COVID has really highlighted, and I think we're still recovering for, and thanks for some of your comments about that. So what are some of the barriers for the future? Well, I think this is one. There are not enough doctors. That was highlighted by COVID. But if you look out through years to come, there is also not going to be enough doctors. And I think really this is something that we're going to have to figure out in the future, especially as the adult and elderly population grows and as new things like COVID actually come along the pike. Now, having said that, it's interesting that the number of people going into medical school is actually increasing. But this isn't really going to help us, at least in the short term, maybe in the long term. That will be helpful as well. And if you talk about nursing shortages, which I wish I had more time to talk to you about, this is obviously a huge problem right now. And if you look at the growth of the population, you can see that in the next few years, our population is going to grow a lot, especially in the older population, and we're going to need people to take care of these patients. When we talk about nursing, it was estimated that there's going to be more nursing jobs than any other profession, actually, in the next 15 years, and we don't have slots for all those nurses, either to be trained or to go into them. And right now there's a shortage of at least 1 million nurses here in the United States. And certainly, the pandemic really caused a lot of stress on our nursing population. And this is a slide from the National Nurses March that took place in May, where they were really campaigning for safe staffing, equal pay, and this whole idea of workplace violence, not something we've ever talked about before that Sri mentioned as well, but certainly is something that's made the nurse and the providers and the clinicians very nervous, actually, about being in their units. Now, I'm not a nurse, but these are some ideas I've had about ways to fix the nursing shortage. I think one of the problems with nursing is people don't respect it enough, and I think this is even true among nurses. Bedside nursing is the bane of our existence. You couldn't do ECMO, you couldn't do anything without them, and so we really need to respect that. Money is a problem. I don't know how much money hospitals can afford, but certainly one of the complaints about nurses is, well, you guys do not cap NBA players' pay, you don't cap CEO players' pay, so you're complaining about travel nurses making so much money, just shut up and get over it. Some of these other things, flexible schedules, weekends only, loan repayment, these are all things that hospitals are trying to do to retain nurses. But if we don't have enough humans, what are we going to do? Well, actually, to be honest, I don't think we're quite to this point yet where we can bring our friendly nursing droid to the bedside, but you never know. It might be coming down the pike in somebody's lifetime, probably not mine. What is our good news? Well, this is a slide from earlier this year compared to later on this year, and you can see that the number of staff shortages really is going down, at least in the United States, although you'll see Minnesota, where 15,000 nurses today are still on strike because of staffing and such, is still out there as a problematic area. What are some good things about the pandemic? Well, as we've heard, I think really consortiums have formed and brought a lot of clinicians together in a way that's never been done before. This is one I'm heavily involved with, the COVID Critical Care Consortium. We have over 20,000 ICU patients with data on there from countries all over the world in every continent. ELSO, has also developed a good bed board, and we had lots of collaboration in terms of sharing knowledge across different centers in different parts of the world. And this is true in the Euro-ELSO world as well. They had this nice survey, and it would be updated all the time with real-time data to show people what was going on. And I think some of that is really going to continue. The other thing that I think is going to happen in the ICU of the future is patient safety and quality are becoming, certainly more and more important. And the ability to use artificial intelligence and machine learning and your EHR and all those things, I think is something that is going to change how we do medical care in the future. We know that the EHR contains a lot of data, but it's hard to get it out. It takes a lot of people, that sort of thing. But I think there are companies now that are trying to help us with this. Of course, they all want to charge money. And at our place, actually, I've gotten a small grant to actually do coding from Epic, which is the EHR that we use, to draw that data directly into a REDCap research database, which I think will be much better for data mining in the future. And because of these things, we can then use that data to develop algorithms of care, identify best practice, and move on. And these are just some of the companies that are out there that provide these third-party ways to stream data to some database. Now, big data is good and big data is bad. And one of the things about it that can be bad is if you're not getting good data, if it's not accurate, if it's not easily shareable, if you can't do it because you're in a low-income country and you don't have an EHR, these are all problems that we have to work on. We have to work on patient safety and who owns the data and all those things that the lawyers will get involved in. But I do think that big data is going to help ICU care in the future. I also think that the ICU of the future is going to be more modular. You're going to have people that are very complex, and maybe your ECMO is going to be kicked under the bed there, but you may get up and be able to walk around with it. There is a lot of cartridge stuff that's coming down the pike and is already almost here that I think is going to make what we do a lot easier. And I think this whole idea of servo regulation, which is already being done in other things like AICDs and insulin pumps, is really something that even at the ECMO and mechanical ventilation level, we may get to over the next few years. So the ICU of the future, I think, is going to become more protocolized. We're going to have alert systems. We're going to have intervention systems. We're going to be able to decrease care variability. And I hate to say this, but there's a lot of data out there that shows that centers have differences in mortality that potentially could be affected if we used best practice processes across all of them. The dangers with this is, though, I don't want to limit innovation and critical thinking. A lot of us grew up in the, hey, we've never tried this before, let's try it era. And I worry a little bit with product protocolization that we may lose that ability. We may become just shift workers who will clock in and clock out. And the patient actually may suffer, I think, from that, because all we're focusing on is, are we doing the right thing by a protocol? So recapping then, I think the ICU of the future is going to be more modular. There's going to be organ support that's sort of like a plug-and-play type thing. Servo regulation is going to be important. The EHR is going to be something that can be integrated with physiologic and mechanical data to help guide care. And certainly, what about ECMO? Well, I have to tell you that I do not believe that ECMO in the future can be done in the ICU. You cannot be having people on ECMO for 200 days or more, taking up ICU bed space. My CV surgeon screams at me all the time about this. And I do think as we move forward, you will see the development of ECMO outside the ICU environment, maybe in the home environment. And I have to be careful here because I believe in this so strongly that I've formed a company that will help actually do remote monitoring and management of ECMO people. But I do think this is something that's coming down the pike. And it's not just me. This is a very recent paper looking at remote monitoring and the use of mechanical support and saying that data can go to an oversight team that can watch multiple patients at a time. It'll help relieve some of our bedside staffing issues. And I do think this is something that you're going to see coming down the pike more in the future. I will just remind you, actually, that ELSO is in 2024 is in Scottsdale, where I live. And if you want to come and have a beer with me, this is my backyard. Thank you very much.
Sorry, I was walking up to get that beer. To keep us to keep us on time and in that window of tolerance that Dr. Porterfield talked about, we're going to shift now to. We don't have time, unfortunately, for questions or for the panel discussion. I apologize. If you have a chance to catch any of our speakers over the next several days, please do. This was wonderful. Thank you so much for all you shared with us. Thank you.